हाँ ठीक आहे, चालू झालं.
Very good morning to one and all. I, Dr. Swati Bhagwat, HOD of Department of Homeopathic Materia Medica and PG Coordinator, on behalf of Dr. G.D. Paul Foundation, Y.M.T Homeopathic Medical College and PG Institute, Kharghar, and Department of Materia Medica, welcome you all for our second national webinar on the topic that has outlived its shelf life. Yes, the COVID-19, the buzzword that still sends jitters and spikes the adrenaline level to pinnacles. This minuscule creature created a ruthless pandemic, beating the historical statistical records of its forefathers by causing more than 55 million morbidities and more than 1.33 million deaths globally, and still remains unsatiated to take these numbers up in exponential proportion, bringing the entire world and economy to a standstill. Vague, unclear epidemiological picture, a wide range of spectrum of disease, and ever-changing clinical presentation requiring a constant change in the treatment modalities are the main hurdles or challenges faced by us, making the containment of disease not only difficult, but also unpredictable. The vaccine still remains a mirage for us. We just can't afford at least 70% of world's population to get infected with the disease to develop the natural herd immunity. So in short, moral of story remains that even after evolving ourselves with this disease for almost a period of 1 year, we are still beating around the bush. Doesn't it remind you the story of 4 blind people and an elephant? The only silver lining to the cloud remains that we are now in a position to find some reduction in the mortality and morbidity rates. Although with recent statistical records, it's evident that some part of the world is on the verge of welcoming the hit of second wave. So with this now, I would like to hand over the session to none other than Dr. Parag Mehta, who is a renowned chest physician practicing in Andheri and Santa Cruz, a graduate from Government Medical College, Baroda, and postgraduate in chest and TB medicine from the same institute. Graduate in chest and TB medicine, he is also a diplomat of National Board in Respiratory Medicine and an active contributing member of Indian Chest Society, European Respiratory Society, and American College of Chest Physicians. Currently, he is the medical director of Schwarz Chest Clinic and also honorary attending to various reputed hospitals in western suburbs of Mumbai since over a decade. He expertises in tuberculosis, especially MDR, respiratory atypical infections, including COVID-19, interstitial lung diseases, bronchoscopic and thoracoscopic interventions, and sleep medicine. He has first-hand experience of treating several hundreds of COVID-19 patients, both as inpatient, critically ill ones, as well as the home quarantines on telemedicine OPD run by his clinic. I welcome Dr. Parag Mehta to enlighten us on the journey of COVID, its clinical presentation, and its effect. Welcome, Dr. Parag. I request you to start the session.
Good morning, madam, and good morning to everyone from G.D. Paul Foundation, as well as anywhere else who are listening to us, either on YouTube or through their laptops, wherever. And I hope whatever Madam said, and I concur with her completely, that this is, a devil's shadow which has been overcast over Mother Earth. We hope that they should sort out sometime in the future, if not earlier than later. And at least the vaccine seems around the corner of the year. Having said that, I thank you once again for the elaborate introduction, and let me not waste much more time. I will start my talk on COVID-19 course and consequences. I'll be briefing you and taking you about how COVID-19 presents itself clinically, and what are its ramifications on the various systems in the human body. I'll try to be as brief and brisk as possible, because it is an all-encompassing problem. And like all other viral illnesses, it can involve almost every system that we can have. So, don't know what's wrong. Just a second. Yeah, are you able to see my slide? Am I audible?
Yes, sir.
And you're able to see my slide?
Yeah, sure.
That's not moving. I don't know what's wrong. There you are. Sorry. Just a second. So certain technical hitches are bound to come in all kind of presentations, and it's a norm rather than an exception. Can you see the image on the screen? So that's basically an electron micrograph picture of coronavirus infecting renal tubular epithelial cells. And this is how it manifests. A single virion infecting a single cell can then multiply exponentially, leading to millions of virions being produced and affecting all other cells around. Of course, the host is basically important for survival of a virus, because otherwise it's a dead kind of an inanimate organism. So this is a Darwin's quote sheet I would like to start. In the struggle for survival, the fittest win at the expense of their rivals, not because they were stronger, but because they were very good at adapting themselves best to their environment. We have a changing environment now. We as medical people have to adapt and help our species to adapt to this change, and bring them through this turbulent time. What are the lessons we have learned from the past coronavirus epidemics? We have had two epidemics from coronaviruses in the past. One was the SARS, that was in 2003, and the Middle East respiratory virus affected in 2013. And both of them had caused significant morbidity and mortality. The SARS-CoV-2 in comparison has a negligible mortality. The morbidity though remains questionable, and it is still subject to being studied. There is a less number of patients who have chronic lung sequelae, although we are very early in the illness, so it would be a bit early to kind of commit to that. We do have a lot of systemic sequelae coming in, just like the SARS and the MERS. We do tend to have a lot of psychological and neurological insults coming in later on. What is interesting to know about SARS-CoV-2 is that the infectivity of this virus starts even before clinical illness sets into the host patient. So patient, before he or she actually realizes that he might be carrying and is infected by the virus, will start spreading the virus to other people around. So the RO, or the rate of transmission of this virus, is around 2.2 on an average. You were to compare it to other viruses like measles or SARS or MERS, it sounds less. But in fact, because of the present scenario of extensive global travel, as well as the relative overconfidence which people had on their healthcare systems, this virus has managed to spread dramatically, like even more than wildfire, and it is almost present in almost all countries of the world now, which is becoming a humongous problem. Interestingly, the very source, Wuhan and Hubei provinces in China, have now been cleared of this virus completely almost, and China is actually censoring people from coming in from abroad, and even the goods are screened carefully. So it's all a U-turn sort of a situation for the world right now. This is a electron microscopy image of the culprit or the villain of the talk today. This is a coronavirus. It is called a coronavirus because it is, it is shaped, or it appears like the crown of a king, and that is where the corona term comes in. This is the S, or the surface spike protein, which is used by the virus to bind to the host cells, and then other proteins are used to kind of, further propagate the life cycle in the host. So let us identify the high risk groups amongst us who are, going to catch it and have a bad illness with COVID-2 or SARS-CoV-2. High risk groups primarily increasing age, male sex, patients who belong to a lower socioeconomic strata and who are from the ethnic minority groups. This is a global sort of a risk profiling. So I am not going to focus on any particular geographic area. The other established host risk factors, the genetics are not yet established, although we now know that there are some blood groups like A positive which are at higher risk. We are still elucidating more about it. If you come to identify specific groups, diabetics are at a very high risk, obese, the pregnant, those who have a chronic cardiac problem or a chronic pulmonary issue, either COPD, bronchitis, or those who have congestive heart failure, ischemic heart disease, and cardiomyopathies. These are at a high risk of complications and catching the infection faster. Those with chronic kidney disease and chronic liver disease, sickle cell disease, smokers, and those who have an immunocompromised host status, either from chemotherapy or cancer or from a solid organ transplant. All of these tend to have a high risk of running complications and a complicated course of the illness. Please take this home, or register this properly. This is a cartoon or an image showing the life cycle of the virus in the host. I'm not going to dwell on that too much. Let us come to the stages of a COVID-19 progression in a clinical case. It has been, for simplicity's sake, identified and divided into three main groups. Stage 1 or the early infective phase. The stage 2 is the pulmonary phase or the pneumonia phase. And the stage 3 is the hyperinflammatory phase. Now, as you can see here in this image, as the viral response or the viral growth starts declining very soon as it peaks, because the peak is reaching even before the clinical manifestations start. So the virus starts kind of declining in its numbers throughout the early part of the illness. Even then, it manages to incite a small inflammatory kind of a response with mild constitutional symptoms. There is some dry cough, sore throat, fever, or sometimes nothing at all. A patient may be absolutely asymptomatic and just be a silent courier for that matter. So you can't even call a lot of them to be patients. Then they come to the pulmonary phase. That is where you have, the involvement of the respiratory parenchyma, the lower respiratory tract, and the patient starts manifesting a dry cough with or without some degree of shortness of breath. This may or may not be associated with drop in the oxygen levels. And the drop in the oxygen level may either remain stable or it may further worsen. This is the time when on investigations you will identify abnormal chest x-rays, and you might have some evidence of early organ injury, either in the form of raised enzymes or raised inflammatory markers. Now then comes in the host's inflammatory response. The virus has died down, or it has dwindled out in numbers, but it has set off a cascade of inflammation in the body of the host. And here is where the music starts. If a patient's body and the inflammatory response system is balanced out and careful in its kind of response to the insult of the inciting antigen or the SARS-CoV-2, generally you will have a moderate or a modest sort of a illness. However, there is a subgroup of patients who tend to kind of have a very hyperinflammatory response or a deviated response, something as you would have in a flare-up of an autoimmune disorder, or something as a kind of a very severe anaphylaxis. Something similar to that, but not exactly the same, happens here also. And so what you get is very high levels of circulatory cytokines and inflammatory kind of biomarkers. And these patients tend to develop progressive worsening of pulmonary function with whiteout of lungs and ARDS. They may also develop circulatory failure and shock. And quite often they also have comorbidities or other illnesses setting in with other systems being involved. I'll not go into the treatment for each one of them. That is beyond the purview of the talk today. Coming to specific kind of situations. So we will divide into mild and moderate to severe kind of an illness. So the mild COVID-19 illness affects almost 80% or probably even less than that, because almost 20% patients may not have any symptoms at all. They're not even patients for that matter. They're just carriers, which the virus is using to spread itself. The incubation period of this illness is generally from 2 to 14 days, and the reporting time in terms of presentation to the clinician is between 3 to 5 days from the beginning of the actual illness. Commonest symptoms being fever. Fever is almost omnipresent in varying intensities, although, and there is no set pattern to the fever. So you cannot categorize it in a particular form. However, you can find patients having cough, sore throat. The cough usually is dry. Only those who have some predisposing kind of a lower airway secretory disorder would have production of sputum. Most of the times they'll also have an associated sore throat and fatigue, anorexia. They also tend to have some degree of breathlessness depending on the extent of parenchymal involvement, and a marked kind of a notification with this loss of taste and loss of sense of taste and smell. So anosmia and dysgeusia are present in almost 40 to 50%. They are not specific though for COVID-19, and you can find them in other viral illnesses as well, but it is a good kind of a giveaway in order to kind of elicit a high risk kind of a or high probability patient. And how do you go about managing them is mostly with home quarantine, social isolation, rest, and symptomatic therapy, adequate fluid therapy. Most patients recover with little or no sequel, and discharge is usually around 10 plus or minus some days, and about 3 days after they have had the last symptoms, whatever it may be in terms of fever. And that is all about the mild illness. Having said that, mild illnesses do come up later on. We will come to that. That's called a long COVID-19. And then comes a bigger group, or the more dangerous kind of a group, moderate to severe illness. About 15 to 20% patients tend to have this. So, and quite a few of them present with persistent high grade fever. And that should be one of the clues to kind of, keep your keep your radar on, and, look for breathlessness, tachypnea, and dropping oxygen levels in these patients. 1 week after the onset of the illness, if a patient complains, you may have treated him with symptomatic as well as probably some antibiotic or something, whatever. And then after a week or so, the patient complains of extreme prostration and breathlessness, and you find them to have a low oxygen saturation. That is very important. That is a giveaway kind of a thing for moderate to severe COVID-19. You may also find variations in the pulse and blood pressure, including appearance of shocks sometimes, which may be very fast. And so these are the patients, especially the high risk groups, who will more likely needed to be admitted in a COVID care facility for better monitoring and aggressive interventions early on. Earlier you intervene, the studies are now showing, the better the outcomes. And so we have a lower threshold of keeping our focus on the high risk group. And that is why one of the first slides to come to you was that about 5 to 10% of these severely ill patients or moderately ill patients would need a transfer to the ICU for probable worsening oxygenation and associated comorbidities, something like a shock syndrome or a DIC or something of that sort. And usually they will have an abdominal X-ray or an HRCT scan if you have been able to get it done. And the RT-PCR will have a low cycle value showing higher viral replication and higher viral load. A brief kind of a comment on the pathodiagnostics. The RT-PCR is the gold standard for diagnosis and has an excellent sensitivity of 70%. Not what really we want. We want much more than that, but it's okay. And you also do the hemogram and the biochemistries for a risk profiling of the patient and a kind of triage of the patient. The timeline of the viral load, we discussed that infectivity starts much even before day 0. The viral peak starts in, and so that is the time when you would actually want to sample. However, anytime during the later week also you may sample and get a RT-PCR positive. And the replication of the virus is now supposed to kind of dwindle out by the 10th day, making it almost, rendering it almost non-infective. That is where the logic of discharging patients early. Radiology is a partner to RT-PCR, and both are in isolation, weaker, but together they are stronger and more helpful. So do not ignore either of the two. Both need to be done. You may do either an X-ray and an HRCT. An X-ray is insensitive compared to an HRCT. HRCT usually get 4 groups. You will get either a typical description or an atypical finding, indeterminate shadows, and non-suggestive of COVID-19. COVID-19 does not generally give out pleural effusions. It does not generally have cavitations. And so they would be non-suggestive. It does not generally have too much of lymphadenopathy. So these are, non-suggestive of COVID-19. You have to look for alternative causes. Having said that, there is nothing which stops patients from having two illnesses also. So interestingly, the Chinese data, came up and they said that tuberculosis patients tend to have a very high incidence of COVID-19. And sharp contrast to that, we in Mumbai have one of the highest levels of drug-resistant TB, as well as incidence of TB is quite high. And however, we don't have statistical data, but I can tell you studies are being in publication, and from my chat with my colleagues as well as my personal experience, tuberculosis patients, at least in our country, are lucky enough to get away with very few infections, if at all, and they are generally mild, do not land up with complications. That does not mean you ask for TB, right? Now, the CT scan reports often mention CORAD. It's a scoring system, severity scoring system, useful only in the early phases when you are actually going to triage the patient. Once a bad lung has set in, it has very little role to play on follow-up. These are some of the slides, and I'll tell you what type of CTs you will see in COVID-19. So ground glass opacities are, considered as a sine qua non. You can find them peripherally placed usually. They may be single or multiple, and they're discrete or coalescing, either of the two. So these are discrete shadows which you're seeing out here, where the arrows are pointing out, that are present bilaterally. And this is a subpleural but coalescent sort of an opacities which you're seeing out here in this CT scan. Occasionally, you may also come with a crazy paving pattern kind of a presentation of infiltrates. And interestingly, with CT scans, what we have found is extrapulmonary scanning being done, and you find incidental lesions being picked up by radiology colleagues when they are facing an atypical extrapulmonary manifestation. And a solitary kind of a infiltrate in a patient with an acute abdomen is a giveaway to COVID-19 infection. This patient turned out to have RT-PCR positive with a CT value of around 21 and was isolated, recovered well, and went home. However, a CT alone wouldn't suffice for diagnosis in COVID-19. So if you look at this kind of a chart, early days, the CT has a kind of a poor predictive value. It's only when your patients generally tend to have either an intermediate or a late kind of a thing that the CT yield goes beyond 50%. And that is the time when you would actually want to kind of pick it up early on. Doing it early, you will get a normal CT scan in around 60% of patients, and so that would not justify the cost as well as the radiation being exposed, with the radiation exposure to the patient. And hence alone a CT scan is not advised as a diagnostic test. So mankind versus COVID-19, we all know, madam has just elaborated, it's a David versus Goliath sort of a situation that we are now facing. We will go through the systemic sequel one after the other. Commonest are pulmonary manifestations, the cough, breathlessness, hypoxemia, affection of lung function, thromboembolism. And in the late stage, you will also come across lung fibrosis and chronic respiratory failure. In neuromyopathies, you will come across pain, paresthesia, neuropathy, strokes, etc. Cardiac, GI, renal, psychological, almost every organ is affected. We will come to that. I'll elaborate a little bit on everything. And you come to the worst part, that is shock, multi-organ dysfunction, and multi-organ failure, with her prognostication very poor, with an outcome which is less than 20-30%, even in the best centers of the world. We are still learning how to kind of improve on that, and gradually we are inching towards betterment. It's a slow process. Learning takes time, especially when it is involving such a huge population. Once again, let me elaborate the high-risk groups. So those who have an elderly age, those who are having male sex, ethnic minorities, socio-economic deprival, as well as those who are diabetics, obese, the pregnant, the smokers, those who have a chronic heart failure or a chronic heart disease, COPD, cancer, some form of immunotherapy or immunosuppression therapy going on. These are all at high risk of developing complications or a complicated COVID-19 illness. What are the pulmonary effects? Airways, bronchitis and airway hyperreactivity are very common. They are very similar to any other kind of a respiratory viral infection, and I'm not going to elaborate on that. Parenchymal involvement comes as consolidation and pneumonias, atelectasis, and ultimately leading to fibrosis and scarring. And thromboembolic events are a typical kind of a presence in COVID-19, which was identified very early on, and I'll talk a little bit on that as well. You can have involvement of major as well as minor pulmonary arteries. This is a cross section of the alveolus, the functional unit of the respiratory tract. All of you are aware of this being the interstitium, which holds the blood vessels, which are important for oxygenation, the alveolar capillaries. The lining of the interstitium is finally formed by endothelium, and the alveolar surface is lined by epithelial cells, both of which face a terrible insult and damage in COVID-19 pneumonia. So what you are seeing on the left-hand side, the image A is what is a normal healthy lung, and the image B is showing the distortion and destruction of the normal smooth layout of the framework of the lungs. So when I saw it for the first time, I remembered only one thing. So that image A is a nicely laid out jalebi made by an expert kandoi or an expert chef, whereas B is a jalebi which I would have probably laid out, something which is made by a novice. It's a total kind of an utter destruction of the normal framework and symmetry in architecture. It's a hodgepodge sort of a thing. That is how healing happens also later on. What you see is neovascularization and extensive involvement of the alveolar epithelium with the viruses. What happens? Almost 5% patients tend to develop this severe acute respiratory insult. They may have pneumonias, they may have lung injuries, or they may have pulmonary thromboembolism. All together also can come in smaller or greater proportions. Severe pneumonia generally belong to the high risk group. They have worsening of the symptoms. The physiology goes for a toss. They may not have hypoxia, but they may have happy hypoxia. I'll dwell on that. They tend to have improved PO2 levels with prone posture, and that is a kind of a good kind of a way to treat them. They tend to have progressive pulmonary infiltrates bilaterally, and generally the lungs seem severely affected and sick. What is happy hypoxia? This is not unique to COVID-19. It has been known to those who are working in cardiopulmonary specialties in the past. It has been seen in shunt patients on a chronic kind of a period of time. But in COVID-19, you get acute severe hypoxemia, and yet hypoxia has been found in these patients. And the patient is basically not perceiving the severe hypoxemia and does not complain of breathlessness or any related symptoms. What are the possible mechanisms behind it? We do not know the exact cause, possible hypothesis. So either there's a neuronal center or the chemoreceptor blunting by the toxic effect of the virus itself, or you have extensive intrapulmonary shunts which are developing gradually, or there's a loss of lung perfusion regulation, which is called as vasoplagia. And so what happens is the vasoresponsiveness of the pulmonary circulation and its synchrony with the neuronal kind of supplies is lost. And that is why the patient does not perceive the drop in oxygen levels. ARDS. So this is not again specific to COVID-19, but yeah, COVID-19 infection with bilateral progressive pulmonary infiltrates. Generally, they are not stable enough to get a CT scan done. They'll need an X-ray portable one. Worsening oxygenation with a PF ratio of less than 2. And there should be normal pulmonary capillary wedge pressure. That's the definition of ARDS. And you cannot have left ventricular dysfunction. If it is there, then it's a kind of a catch-22 situation, whether you are looking at pulmonary edema or whether that's cardiogenic or non-cardiogenic. So this is non-cardiogenic pulmonary edema or white-out lungs. This happens primarily because of flooding of alveoli by the inflammatory process and inflammatory debris as a result of the process. There are certain efforts to phenotype ARDS and which might help in management of the same. So the L phenotype and the H phenotype, I'll not dwell too much into that. Lung fibrosis is what happens after the infection is burning away. Interestingly, for COVID-19, lung fibrosis sets in much faster than other illnesses. These patients generally have a history of having a severe COVID-19 lung infection with associated severe hypoxemia for a significant period of time. We find it very difficult to wean them off the oxygen levels, even for a short period of time, because of the fibrotic changes which have already occurred. I had shown you that jalebi sort of a thing. So that jalebi sort of a thing then actually organizes itself into a scarred sort of a tissue, and that is what is lung fibrosis. So the lung compliance is lost, and you get a lot of stiffness in the lungs. So the patients find it very difficult to breathe at that point of time. So the hypoxia time has gone up, and the patient realizes that he or she is really having some problem with the health. And the radiology obviously confirms fibrotic damage to the lung. A CT scan is definite for a definitive investigation, because a X-ray may not be very sensitive or nor specific for the fibrotic process. This is how a fibrotic process would look. So this is the only normal looking area, or the apparently partially normal looking area, this part and this part in the lingula, but rest all is affected significantly. You get a lot of interlobar, interseptal septal thickening, and some degree of honeycombing coming in. There's a lot of traction bronchiectasis also which has come in. And the thing which I just mentioned, the rapidity of onset of fibrosis. And on the left-hand column, what you are seeing is a CT scan of a COVID-19 patient in the acute phase with a consolidation which is peripherally placed. Within a matter of a week to 10 days after re-imaging the patient, we found him to have developed this sort of a severe interlobar and interstitial septal thickenings. And that was bilaterally present. This is the bronchiectasis, the traction bronchiectasis I was mentioning. And these patients tend to have a relatively difficult time. Next comes thromboembolism. So, of course, these patients have a reduced mobility and relative stasis. They are dehydrated and have a poor intake of water. They are tachypneic. They have a associated comorbidity, and there was severe inflammatory process going on, leading to high cytokine levels. And I had mentioned the endothelium of the vascular kind of a framework of the pulmonary bed, as well as the alveolar surfaces. They both go and face a lot of injury and trauma from the inflammatory insult. The endothelium, once it is injured and it's the underlying intima is exposed, the ultimate kind of event which happens is a thrombotic process. To add on to these things, or the last straw on the camel's back, is the hypoxia, which is very difficult to kind of alleviate and improve. And as a result of the hypoxia, the DIC sets in. There is a lot of micro as well as macro thrombus formation, and interestingly, this affects the entire vascular bed. There is no specific kind of a cutoff, in the sense that it can be confined to one part of the vascular bed. You will also see, as a result, a lot of derangement of the coagulation profile and the coagulation markers, along with thrombocytopenia. So as you can see here, it affects all levels on both venous and arterial beds. The pulmonary arterial bed, you are seeing here thrombus in the mid-sized pulmonary artery. This is in a small sized arteriole. This is a pulmonary parenchymal infarct. And these are diffuse alveolar damage, sort of a thing, with alveolar arteries being completely damaged and thrombotically occluded. And how do you diagnose pulmonary thromboembolism? You need to have a very low threshold of suspicion for this. There has to be discrepant radiology, and the blood gas will show significant hypoxemia. The X-ray parenchyma may or may not have such a bad sort of a picture. That is associated with some degree of hemodynamic instability, some persistent tachycardia which is unexplained, and subtle signs of right heart failure which come in. You get a CT pulmonary angio, you will find something like this. This is a saddle thrombus, which is actually occluding almost the totally right main pulmonary artery is almost totally occluded. The left main pulmonary artery almost 50% is occluded. This is a massive or a submassive sort of a pulmonary embolism. We use the D-dimer, the platelet counts, and the fibrinogen and INR levels to kind of identify this process and manage it actively. The important part to kind of focus on is the cytokine storm. It has been much talked about. What actually happens is the COVID virus actually leads to significant activation of our protective cell-mediated immunity, the macrophages, the dendritic cells, and the monocytes. They are all kind of put into a kind of a recharge or a high charge sort of a state, and all of them start releasing interleukin-6 in huge amounts, along with interferon gamma and other pro-inflammatory cytokines. The interleukin-6 by itself is a propagation kind of a messenger to other cells also, and hence it results in a lot of further signaling and lymphocyte activation. It also leads to endothelial cell damage, as well as further propagation into the systemic circulation, as a result of which you get what is known as a toxic shock syndrome or a cytokine shock syndrome, hypotension, and these patients generally also associatedly have acute lung injury and ARDS. So COVID-19 interleukin-6 levels are closely associated with complications. And so almost 3 to 5 times the levels have been found in patients with complicated COVID-19 for interleukin-6 versus those who have non-complicated illness. So this is a famous quote from Winston Churchill: if you're going through hell, you still keep going. You'll still go further through some difficult times. Cardiac presentations: these patients can have myopericarditis, heart failure, arrhythmias, myocardial infarctions, stress cardiomyopathy, and of course the thromboembolic effects, which we just talked about. Almost one-third of these patients with COVID-19 of a severe nature develop cardiovascular effects. The elderly are at a very high risk of developing atherosclerotic events and strokes. The younger tend to develop myocarditis and congestive heart failure with preserved ejection fraction, or sometimes conduction defects like a heart block. And this is quite often overlooked if not looked for, especially in somebody who is younger and relatively stable. What are the mechanisms? A direct myotoxic effect on the myocardial cells by the coronavirus, because these also express a lot of ACE2 receptors, which are favorite for the COVID-2 virus. Hypoxemia and cytokine mediated damage, along with an increased demand of functioning from the myocardium with a poor supply of oxygen and a diffuse inflammatory kind of a state leading to DIC and coagulation defects everywhere. This leads to this complex of cardiovascular dysfunction. And if you were to look at the timeline of the events in an acute phase in the early 2 to 3 weeks, you will generally see myocarditis and cardiac failure with low ejection fractions. Later on, you will see delayed myocarditis, conduction blocks, sometimes cardiac arrest, and cardiac failure with preserved ejection fraction. Neurological effects, presenting features in almost 36% patients. We have a study going on in the neurophysicians of Mumbai. There is a consortium. They are looking at GBS incidence in COVID-19. And I'm very happy to say that, India is also gearing up with its own literature. Very soon, we will have a flood of literature coming up in all journals everywhere. What are the features? They generally tend to be older patients, tend to have less respiratory manifestations, significant amount of comorbidities they have, and of course they have a high viral load. They are potentially very infective because you are not focusing on the primary problem. You are missing out on COVID-19 as an infection and a culprit, and the focus is on the neurological insult. They tend to land up with more severe disease, often passing away because of the neurological sequelae. Symptoms: impaired taste, smell, vision and speech disturbances, weakness, loss of function, dizziness, imbalance, and paresthesia related to neuropathies, seizures, and convulsions. So they present with strokes, seizures, meningoencephalitis, myelitis, or as I mentioned, GBS or AIDPs. Myositis is not uncommon. You can have it with or without neural involvement, with muscle aches, body pain, and myositis. And usually they tend to have some form of kidney injury associated with that. Psychotic or psychobehavioral issues are kind of increasingly seen. Almost everybody, it's universally present. Anxiety is there. Everybody is stressed out, and there's a fear of unknown. What's going to happen? Mera kya hoga? Uska kya hoga? You are worried about your loved ones. There's a post-traumatic stress disorder for almost all healthcare workers who have been working in COVID units, as well as those patients who were admitted to COVID-19 units, whether sick or not sick. Even the non-sick, not really sick patients, but mentally weak patients tend to kind of develop PTSD. Somebody who has been a borderline kind of or a Humpty Dumpty psychiatric patient, develop a depression, overt depression, panic, OCDs, or psychosis in these patients because of the deprival and isolation which they have to face. Behavioral issues are very common. We also see an increasing amount of substance withdrawal reactions because they had been deprived of their abused substances, as well as an increasing use or abuse of substances of abuse because of the socio-economic deprival, the socio-economic affection, as well as the stress arising out of the illness itself, and the fear of the stress, fear of the illness. GI manifestations. Occasionally, they are the only symptoms reported, and patients may not have had any other symptoms whatsoever. So it may be passed off as a, khane se ho gaya and theek hu main abhi, I am fine. And then they manifest with some later manifest kind of insult. So what are the symptoms? Anorexia, diarrhea, nausea, vomiting, abdominal pain. Well, you see all of these are very non-specific kind of a symptoms and do not give you a clue initially. You have to have a very low threshold of suspicion for COVID-19. They could manifest as hepatitis or enteritis or colitis or a flare-up of a pre-existing simple disorder like a gastroesophageal reflux. Even our medicos, almost 30 to 50% have reflux disease. You can have celiac disease or IBDs, IBS, and malabsorption. So all going in, their control is gone for a toss. The patients might have not been compliant, or the need for the medication dosage increases. Acute kidney injury is a hallmark of very severe sort of a COVID-19 infection and has a close correlation with mortality. And if managed carefully, you might need to kind of, sometimes have to institute renal replacement therapy either in the form of hemofiltration or hemodialysis. The patient is really bad, because this is one area which is potentially very, very kind of manageable and has a very reasonably good outcome if you manage properly. So this is Joseph Borrell. Joseph Borrell is the fellow who is leading the committee of the European Union against COVID-19, and he says that COVID-19 will reshape our world. We don't yet know when the crisis will end, but we can be sure, but by the time it ends, our world will look very different. I mean, it can't be better said than that. What are the endocrine manifestations? There is documented thyroiditis and dysglycemia. So those who have diabetes mellitus or impaired glucose tolerance or impaired glucose metabolism, this goes for a toss. They need regular follow-up. Pediatric COVID-19, this is very interesting. So again, here children have proved themselves different and more kind of capable than adults. We are not young adults. Stop treating them as that. They have a very low incidence. They have mild presentation, fewer admission to hospitals and ICUs, less mortality, having non-specific symptoms like coryza, GI, and arrhythmia of the pharynx, some fatigue, some diarrhea and irritability, some skin rash here and there, and it goes away, and they are fine. And then they go to the pediatrician. The innocent pediatrician examines them carefully. He tries to play with the child. He catches up infection. A huge number of our pediatric colleagues have caught infections. In fact, in our neighboring state of Gujarat, there has been a high incidence of mortality in pediatricians. So one has to be careful. Pediatric multi-system inflammatory syndrome or toxic shock syndrome, this is something which has been identified later on, not in the early phases of the illness, but these bachus tend to have persistent fever with persistent uncontrolled inflammation and evidence of organ dysfunction. They tend to have some or the complete profiling of Kawasaki disease. So it's like an aorta arthritis sort of a thing. And then they have absence of any other documentable infection. No bacteria or virus is isolated anywhere, except for possibly SARS-CoV-2. The PCR may or may not be positive. Sometimes you may land up with just seeing antibodies. That was about COVID-19 and the children. And let me tell you that by that standard, COVID-19 is a chivalrous bug. I would say, it is mild and soft to the ladies and to the children. And it is really harsh on the elderly gentlemen. Dermatologic manifestations, almost 20% patients develop skin rashes sometime or the other in the natural course of the illness, quite often overlooked or underreported. There is no single classic sine qua non lesion. Chilblain types lesions you can find. You can have papillae coming up. You can have acral lesions with crusting, some erythema or erythema with violaceous lesions, morbilliform, horrible looking rashes all over the trunk and the upper torso. Or you can have dangerous looking petechial hemorrhages sort of on patients, especially with thrombocytopenia, along with some erythematous maculopapular eruptions like measles or German measles. An interesting area here is, the PPE-induced skin injury and dermatitis, which happens especially in healthcare workers. People like you and me have been using N95 masks for several hours together, leading to kind of bruising of the skin, pinching of the skin, break in the integrity, and ulcerations have been found in severe cases, especially those who have had pre-existing skin weaknesses. And well, there are ways and means to work around it. Of course, one has to be very, very careful not to expose oneself to SARS-CoV-2 intensive areas. Hand hygiene related dermatitis is an all prevailing thing, can happen in normal people as well, because hand washing is recommended for everybody. And if you are using non-alcohol based hand wash with amines, or if you are using a hand wash with a lot of additives, colors and lot of perfumes added to it, you can develop this. If you are allergic to latex and more latex gloves, you can get it. You need to kind of work around it, and there are ways and means to treat this as well. Ophthalmology, conjunctivitis is the most important and commonest manifestation. Bilaterally mild follicular type, not really much of a worry, but the problem is the spread to our colleagues who are working in ophthalmology. They work in very close association with the patient, putting them at risk. Long haulers or long COVID-19 is the latest kid on the block. So these usually are, sorry, patients who have had sort of a severe illness. They present with a long-term sort of a fatigue, shortness of breath, cough, and body pain, chest pain, which are not explainable with the present profiling, present symptomatology and physiology, and their present investigations are all normal. Some of them also tend to have some cognitive defects and brain fogging, forgetfulness, depression, muscle aches, intermittent fever, low-grade palpitations. It can last up to several weeks to months. The elderly, those who have had a severe COVID-19, those who have had a prolonged hospital or an ICU stay, and an interesting group is young females who have not been having any of these, and yet, they may land up having these problems. We are yet to find out why it happens and how to treat it. A significant amount of, or a significant number of these patients tend to manifest psychological or psychiatric disorders later on. What is the take-home message for all of us out here from me today? COVID-19 is a new viral illness. It has myriad manifestations. Do not be overconfident when you're sitting at your desk in the OPD. It can range from asymptomatic to a critical illness causing death very soon and very effectively. It is very important for all of us to avoid infection, as we still don't have an effective cure. And the only way we can avoid it is the SMS kind of a thing, so social distancing, masking, and good hygiene of the hands. As number of the patients increase, we will see more and more patients who have atypical presentations, unexpected kind of manifestations, and new illnesses are going to be explored. We are still learning about it. Having said that, it's a mistake to look too far ahead. Let us not be very pessimistic about this problem. We have all united as a world, as a country, and as a city also. We are all together into it. Only one link in the chain of destiny can be handled at a time. Sorry. This is a man, Winston Churchill, took his country out against the Nazis with nothing in his hands in the 1940-42 era, when Britain was the sole surviving fighting country against the Nazi onslaught in Europe. And yet with persistence, perseverance, and excellent craftsmanship and good leadership, with a indomitable willpower to succeed and to survive, that is what kept the Britons alive, and kept fighting, and then eventually they won the war, especially when United States stepped in. So we will also continue to fight. We are not going to lose, and be hopeful. We will be winning this war. Thank you all for your patient listening and for the invitation. Thank you, my family, for the support, my teachers for teaching me everything, and of course, nothing would have been possible without the internet today. All these resources, a lot of these images are from my own collection as well as from the internet. Thank you very much.
Thank you, Dr. Parag. Absolutely amazing session, enlightening session, and definitely we will be benefited by your talk, especially as a homeopath, as a physician. What we are going to get is patients coming to us in coming near future who have already received the infection, and then how to deal with it, a better clinical approach in understanding this patient. Now, having known this course of disease from allopathic perspective, for we homeopath, it is imperative to correlate it to the homeopathic principles. Homeopathy, the unique and holistic system of medicine, has always tackled the pandemic situations with a great success right from centuries.
and it has been doing so in this pandemic also in Hong Kong or in China or in some European countries. They have successfully treated cases by use of medicines like gelsemium, rustox, bryonia, arsenica malbum, etc. Even Ayush Ministry is promoting the use of these medicines for better building up of the immunity. Okay, so with this, whatever Dr. Parag has explained to us, so in view of that, here now we have Dr. Chintan Mehta, who shall be highlighting on an outlook of various homeopathic remedies that can come in course of COVID-19 and its consequences, with special reference to the clinico-pathological dimensions of these remedies. Okay, so Dr. Chintan Mehta, a face well known, of course, to Y.M.T's and all over Maharashtra. He's a clinical has a clinical experience of practicing classical homeopathy for more than 20 years. He is an expert analyzer and master prescriber. He has graduated from Anand Homeopathic Medical College, Gujarat, and has taken PG training in homeopathy from Institute of Clinical Research, Kharghar. And he's a MD from our own institute, Y.M.T Homeopathic Medical College. Currently, he's working as an assistant professor in Department of Homeopathic Materia Medica and is a guide for pediatrics. So now I hand over to Dr. Chintan Mehta. So for better understanding of perspectives of homeopathic remedies with special reference to their clinico-pathological understanding in dealing with cases of COVID and its consequences. So welcome, Dr. Chintan. I request you to start your session. Thank you.
મારો ફોટો આવશે મારો ફોટો આવ્યો એ બેસું ના હું કેમેરા ઓફ કરી દીધો મેં કેમેરા ઓફ કરી દીધો છે ચિંતન એકવાર બોલશે બોલે ન સંભળાય મારે સંભળાય ફોટો ભલે જોઈ કેવી રીતે બોલે છે મારે બી પછી મારો બી આવે ફોટો આપણે એમાં શું છે ફોટાને બધું વિડીયો બતાડીએ ને તો આપણી બેન્ડવિડ્થ વપરાય મારો ફોટો નહીં આવ્યો હા બેસો ને કેમ બેસો એટલે તું કેટલું મારો ફોટો ચિંતન પેલું
Sorry for the technical disturbance. Give us a minute to resume back with the session of Dr. Chintan Mehta.
Again, am I audible? Yeah. Give me some thumbs up so that I know that I'm audible. Anyways, uh, yeah. It is interesting, if you have attended Parag's presentation, Dr. Parag's presentation, it is interesting to see that the virus per se doesn't cause so much of a damage as much as the body's altered immune response to it does. You see, or rather to say, an over response or a distorted response to it does. And with this, it becomes interesting and important to identify and treat, you know, personal idiosyncrasies, personal susceptibilities through homeopathic medicines, which has a variety of homeopathic medicines with different symptomatology. I would like to dedicate this lecture, this seminar, on a lighter note to all those who broke their heads in this lockdown of COVID-19, attending webinars on COVID-19, attended many but hardly got an opportunity to treat any. And I believe they are so exhausted, they are not ready for anything more. With the blessings of this was on a lighter note, dear ones. With the blessings of the Almighty and in the divine presence of Master Hanuman, expressing my heartfelt gratitude to the entire team and management of GD Pol Foundation, who is behind this. Heartful thank to our Dean, Dr. Page Madam, and Dean Faculty, Dr. Bagal Sir, both strong pillars of support. Our HOD of the Department of Materia Medica and PG Coordinator Bhagwat Madam for her hard work and constant endeavors. Again, strong supporting hand. My departmental colleagues, Dr. Vinod Sawant, Dr. Neena Menon, Madam, and Dr. Neela Masavle, entire staff and faculty of Y.M.T Homeopathic College for inspiring and supporting us. What I'm going to talk over here right now is not give you single symptoms of a drug, or give you rather, or share with you rather my favorite remedies for COVID-19. Therapeutics is not about my remedy, your remedy, right? I many a times joke, when two homeopaths gather together, three homeopathy comes up. एक मेरा होम्योपैथी, एक तेरा होम्योपैथी, दोनों मिल गए तो एक थर्ड होम्योपैथी बनता है, उसका होम्योपैथी. This is not what homeopathy is all about. Homeopathy is all about, that's what I told in the beginning, identifying those individual personalities, individual susceptibilities. And that is what we are going to see. What we'll learn in this 45 minutes to an hour, whatever time you have and I have with you, is how COVID evolves in different medicines. What are the peculiarities of those medicines? In light of not just what Dr. Parag has told, the clinical pathological correlation, but also what our masters have laid down in our source book, Materia Medica Pura, Herring's Guiding Symptoms, Allen's Encyclopedia, etc. All this through a method called case simulation. I'll be sharing a couple of cases of mine too, if time permits. But basic method is case simulation, and ladies and gentlemen, it's going to be an interesting 45 minutes to an hour with me. Hang on to your screens. And a suggestion. I'll be presenting you the symptoms of the drug. Whatever drug you have in your mind, before I click the drug button, put that drug on the YouTube message box or in the chat box over here if you're joined to us with Zoom. I'll be sharing my screen. Fine. Okay. Before we go to the therapeutic aspect, it is important to, before Materia Medica comes organon, how to work out the case. And in homeopathy, you look at peculiarities. When you are looking at peculiarities in a case of COVID-19, it is important to know which angles in the case you will look at those peculiarities. So first, you can find a peculiarity in the comorbidities. Yes, which comorbidity a patient is coming to with. Going ahead, you will see different drugs will have different comorbidities. Parag had highlighted the entire list to you. If the patient is coming to you after he has after the infection has subsided, the post-COVID, then what were the symptoms that the patient had during COVID infection? If in case he is coming to you as a fresh infection, then what are the signs and symptoms which are present of COVID-19 and how they have evolved? Also, which parts are affected, which part or which parts are affected. And last but not the least, the pathology. What is the phase of that pathology and what miasm is this case speaking of or hinting towards? Next to creating a life, the finest thing a man can do is save one, none other than Abraham Lincoln, a man who valued values more than anything. It's all about saving lives, friend. I'll be talking on two topics today. One is active COVID infection, wherein the life is at threat. And second, once the COVID has subsided, things like interstitial lung fibrosis, post-COVID weakness, fibromyalgia, which drugs can come up. But before that, how to save lives, right? Pneumonia in old age, killer combination, okay? If an old patient is coming to you with pneumonia, it's a diagnosed case of pneumonia or about to be diagnosed, the symptoms are suggesting. Many a times it may not. Fever with weakness, if it is a common symptom, which drugs will come? Okay, interesting. Sure. Lung parenchyma is involved. This is the way we'll go about. Pathology is pneumonia, fever with weakness, the symptom, lung parenchyma, comorbidity is old age. Okay, so obese patient. This again is a comorbidity with old age, but becomes more dangerous. Known case of rheumatoid arthritis or acid peptic dyspepsia. Coming with history of or the presence of a low-grade persistent fever since few days. Low-grade persistent fever. It started with cough, violent cough, dry cough. But after a few days, say 7 days down the line, the cough became weaker. So violent tha, it became weaker. And now the cough became weaker, but the patient is developing dyspnea, and not just dyspnea, orthopnea. Orthopnea, oppressed feeling in the chest, maybe there, may not be there, but orthopnea definitely occurs slowly over a period of few weeks. Weakness is there, and there is loss of thirst. You can write down the drug which is coming in your mind. Loss of thirst, decreased appetite. The patient was dull initially and gradually is becoming drowsy. Definitely hypocirculation, so he'll become drowsy. Bronchi and lung parenchyma are involved. Inflammation manifested in the form of pneumonia and bronchitis and going towards ARDS, kissing ARDS. Okay. Miasm is psychotic. Pace is slow and persistent. You can guess the remedy. Okay, the remedy is antimony crude. Antimony crude. Ailments from bathing can be a confirmatory symptom. Many people are complaining with ailments from bathing, so I'm not giving it much of importance many a time. But you may get it, right? You may get it. Many of our patients are there, okay, including the one who's talking right now. Antimony crude. Which are the confirmatory symptoms of antimony crude? Coated tongue, dirty look, cracked corners in the mouth. Okay, cracked corners in the mouth. Yeah, dirty look problem is bloody hell. When I'm practicing in Andheri, I don't get patients with dirty look. Makeup लगा के आते हैं, foundation लगा के आते हैं. COVID के लिए. Okay. One thing is certain, but when an antim crude will come, withdrawn look, withdrawn state of mind. He will not allow you to examine. He will not like you waving him. Pediatric cases, of course, not for COVID, but which I have treated with antims, all antim tart, antim crude. They will, give a cross look many times. When I say bye-bye, or the mother says, doctor ko bye-bye bolo. Child, 2 minutes to humko shak lagega yaar, mere mein koi problem nahi hai. No, it is the patient who has the problem. And it is almost a confirmatory sign for me to prescribe an antim. How you differentiate with antim tart? If you want, I'll talk about it later on, right? Old fragile patient, probably a chronic diabetic, okay? Having rheumatic complaints also, good drug for that also. Recent issue of fever with weakness, coryza with chilliness, sneezing, less likely in COVID, but sneezing with a desire to cover. Severe weakness, यहाँ इतना mark मैंने बताया नहीं, but severe weakness, almost collapsing from stage 1, and with body pain. In a day, in 24 hours, at the most 48 hours. Or after a few days, but suddenly he starts sinking. He may complain or may not complain of a precordial distress and vertigo. Before you can even ascertain the cause, the patient is collapsing. पिताजी हाथ में ही कमजोर होने लगे. He started sinking in my arms. Okay, fast-paced drug. almost dead unconscious, very fast pace. That is camphora. You might be wondering, Dr. Chintan, what are you saying? Desires for cover, camphora wants to be uncovered. Dear ones, possible, possible. It is aggravated by drafts. Aggravated by drafts. So in initial stages, they will want to cover. You can refer Kent if you wish. But in this stage, later on, in the stage of collapse, they will want to cover when there is coldness. Okay, that is camphor. You may not be able to ascertain the cause. क्या होगा cause sir? Pulmonary embolism हो सकता है. It has spasm of pulmonary artery, as per Clark. And if you read Boric, wonderful heart stimulant for emergency use. Heart stimulant for emergency use. Some of the doctors, I don't know the name, they recommend keeping camphora bottle. Every homeopath must keep a bottle of camphora in his pocket in case he is coming across an emergency. And no wonder it was recommended as a genus epidemicus by some very responsible quarters. But will it come in all cases? I don't want to comment much on that. Okay, spoiled cases. Spoiled cases. बराबर बिगड़ा हुआ case. Cases with suppression. You will say suppression, sir, in this COVID era. Everybody is taking drugs. How will we know whether there is suppression or not? I'll tell you. High grade fever and you are subjecting the patient to cold water sponging. Recommended is tepid water sponging. Second, many of my friends, patients, weird behavior in this COVID era. Probably fear psychosis or what. Few drugs were popular, azithromycin, chloroquine. So they start taking azithromycin before going to shopping. This is suppression. This is suppression. Low grade fever, if you are suppressing with an antipyretic and the patient comes down in this state, it is camphor. Low grade fever, which does not require an antipyretic, if you suppress it and if it suppresses and quickly the patient goes into collapse, camphor is the drug. Okay, aggravation by suppression in the very word of Fata. Spoiled cases. Okay, not recommended intubation and still intubated, and the patient, doctor is trying, and the patient instead of improving sunk. Spoiled case. Okay, dry collapse. There is no discharge, no diarrhea, no vomiting, nothing that heralds a collapse, anti-collapse. That is camphor. Full drafts again. Next. History of hypertension, sleep apnea, or COPD. कैसे sleep apnea? The drug has daytime sleepiness. It has snoring also. Okay, think and write down what drug comes to your mind in the message box. After few days, the SpO2 falls down. Not immediately like camphor. After few days, probably a week down the line. Presence of COPD and sleep apnea suggests that probably a pulmonary hypertension is going on. Okay, there may be a fibrosis also pulmonary within the arterial walls. Cough with rattling of mucus. Rattling because the COPD is there. Okay, and gradually the patient becomes dyspneic, breathless. Okay, and the breathlessness initially is worse on exertion, but later on it becomes worse on sleeping. The patient cannot sleep, just like your lecasis patient. Okay, gradual, but definitely it is occurring, right? But unlike lecasis, it is not that septic. Lecasis is very septic. This is not that septic, but definitely there is an aggravation from sleep. Worse in a warm room, again lecasis. Better by air condition, although the patient is chilly. Okay, and then if not tackled over here, he'll be collapsing. Pulmonary hypertension, this indicates, if you are heard Parag properly, pulmonary hypertension going into pulmonary edema and the back pressure going into right ventricular failure. The drug also has pedal edema. Okay, remember this. Gradual miasm is psychotic. As per Clark, a drug for under oxygenation. You can write down your views now. Write down the drug which is coming to your mind. Ammonium carb. Okay. Right. Remember this. We'll be comparing this with another drug going forward. Thoda yaad rakho. Much more important to know what sort of a patient has a disease rather than the sort of a disease a patient has. None other than William Osler, father of modern medicine. He is also suggesting know the patient. So how is ammonium carb patient? very much like natrum. Like lecasis तो बताया है मैंने, aggravation from sleep. एक और symptom याद करा देता हूँ lecasis का. Vindictiveness like lecasis. Hatred and revenge like lecasis. Brooding like natrum. Dwells on past disagreeable occurrences natrum. Dwells on what others did to trouble you. Ammonium का. मूड बिगड़ा हुआ रहता है. If when he is in COVID, करके बैठे रहेंगे. Ill-humored in stormy weather. Probably that is a symptom of only drug ammonium carb, probably. But ammonium carb is there, right? But unlike lecasis, it is right-sided. And like sulfur, dirty. बराबर? तो बस right-sided है, but better by lying on right side, keeping things inside, keeping grudges inside. Can we coin it in a way? Can we generalize it in a way? This is my doing. Likes to sleep on their pains, and then a COVID coming up. Food for thought. 5 gems for pneumonia. Okay, I won't be giving you all the drugs as I told you. I'll be giving you few drugs which are important. The 3 I have given you, if anyone is thinking they are not important, just refer Kent, dear ones. Okay, Kent's trio of octogenarians: ammonium carb, antimcrude, camphora. Kent's trio for octogenarians who acquire pneumonia or cold immediately and going into a pneumonia. These 3. These 5 are also wonderful remedies. They will come very often in COVID. How they will come, if you wish to know, you can pop your questions at the end of the webinar. I'll definitely help you and give my views on this. My views on this and what has been mentioned in the books. Arsenic alb, I won't talk much. I'll be talking as and when we go through. You know, arsenic alb will be compared with almost many of the drugs. So I'll be talking about pulmonary thrombosis. Okay, another deadly presence in COVID. Known case of ischemic heart disease. Known case. He has a history. Left ventricular failure or sleep apnea. The drug is snoring also in this. Comes with cough with bloody sputa. All of a sudden, he becomes breathless. He must lie down. This suggests that there is a breathlessness, wanting to lie down, wanting to sleep. This is peculiarity of the drug. Aggravated by sitting. Ammonium carb में क्या था? Aggravated by lying and aggravated by sleep. बराबर? यहाँ पे थोड़ा उल्टा है और sudden onset. ठीक है? Patient gets vertigo, fainting attacks, fainting fits. ये कोविड हुआ है तभी भी हो सकता है pulmonary embolism. COVID went away and then two those remnants are there and he gets fainting attacks. This suggests pulmonary embolism. Low blood pressure, patient coming to you like this, the first thing you will think of is pulmonary embolism. Coldness not relieved by warmth. Patient may become unconscious, may not become unconscious. You don't, well, I would like to see the patient when he becomes cold and unconscious, right? It can be caught early. The drug can be caught early and the patient can be saved. My purpose for giving these presentations is you can save the life of a patient early. Homeopathic intervention, if it is done, right? Blood pressure is low, SpO2 is falling down, pulse and respiratory rate are irregular, D-dimer is positive definitely, and pulmonary hypertension going to thromboembolism. Wonderful drug friend. Lorocirrhosis. Lack of vitality in chest and heart affection. Lack of vitality in chest and heart affection. You can refer the source. Okay. Lack of vitality, many drugs are there. Opium, valeriana, the list is long. 5-6 drugs are there. Capsicum. In chest disease, heart affection. And you'll be surprising why so much of virulence in lorocirrhosis. It is acute to subacute state. But if it is acute, then one of the active principles which lorocirrhosis has, which makes it so violent, is hydrocyanic acid. Hydrocyanic acid has also a state of collapse due to pulmonary condition more than a cardiac cause. Lorocirrhosis both cardiac and pulmonary, right? Lack of reaction in chest and heart, clutches the heart with hand, gasping for breath. Better by spreading arms like Soraya. ये improvement, amelioration मिल भी सकता है, नहीं भी मिल सकता, बराबर? But it has. Just go through this. Just read this. Feeling suffocated from regulations. typical COVID behavior has come up these days. COVID appropriate behavior is suggested, but how long can a person's idiosyncrasies and his susceptibilities, his tendencies, his mind, prevent him from behaving what he originally is, right? This statement is a perfect example of that. Feeling suffocated from regulation. Set rules make me nervous, doctor. हाँ? रोज सर सुबह उठ के दूध वाले के पास से दूध लेना और फिर हाथ धोना, मास्क पहनने के बाद ही ये करना, मेरे योगा क्लास ये टाइम पे होते हैं वो मैं ज्वाइन नहीं कर सकता हूँ, मैं जॉगिंग पे जाना चाहता हूँ वो मैं नहीं जा सकता हूँ, मेरी लाइफस्टाइल जो है वो ब्लॉक हो गई है, एंड दिस मेक्स मी सैड एंड डाउन. Okay, sadness by impeded respiration. Sadness by impeded respiration. Respiration is what? Inhalation and exhalation. Inspiration and expiration. It is life. If that life is blocked, this fellow becomes sad. And with this sadness, will he remain where he is? A patient like magnesium with his sadness, he may remain where he is. Pulsatilla, he may behave how he is. He can be dominated. This fellow is frustrated. It drives him out of the house. I do not like to remain constrained by established rules. Irreligious. I desperately feel like coming out of this confines, shrieking for it, and anxiety is better in open. भाई खुलापन चाहिए लाइफ में, ऐसा बंद नहीं पसंद. मास्क पहनो, हाथ धो, बंदियार लगता है, कंस्ट्रेंड लगता है, and feel sad when others are blaming or criticizing. Lorocirrhosis is the term. Lorocirrhosis is the term. Right? Very interesting, very important. Next, known case of diabetes or cancer. Known case of diabetes or cancer. Barabar? Now complains of fever with weakness, with profuse sweat, especially at night. चलो ये भी दे दिया, एक clue दे दिया, पर जरूरी नहीं है. ये direct questions होते हैं आपके end में confirmatory question, but I gave it initially. Cough on inspiry, dyspnea, hissing like a snake. This hissing like a snake does not come in practice or in hospital, but it is there in the book. So I mentioned it's a clue. It does not come in practice. Cough on inspiration. If you have not tackled this fever, it will go to cough or it will come together. And if not tackled here, it will go in right ventricular failure and pedality. Thirstless patient, burning in the chest and coldness. Fantastic drug for gastric cancer. Flu area. Patient is going from pneumonia, probably ARDS. Pulmonary edema is going to heart with pulmonar. Remedies. करो थोड़ा लिखो थोड़ा. Yeah. Subacute state. Acetic acid. And what does boric say for acetic acid? If you had heard Parag properly, na, jalebi दिखाई थी Parag, right? Deposits होते हैं, right? In the alveoli, in the interstitium, deposits होते हैं. Okay, this drug, boric mentions, liquefies fibrinous deposits and albuminous deposits. Think about it. Carbohydrates. I fear this drug will be abused a lot by hospital people. On a very serious note, let me dedicate this entire webinar, my lecture at least, to all those COVID warriors, frontline COVID warriors, those homeopaths, those interns, those postgraduate students who are working hand in hand with allopaths as frontline COVID warriors, who are functioning in their individual OPDs and hospitals, treating COVID patients, helping COVID patients, risking their lives. This is a Diwali gift from me. Take it. I am giving you not just tips, but I am giving you when these drugs will come and when these drugs will not come. You may be having a different opinion, my friend. But if this lecture can just stimulate in you an idea as to go to the source books, please do it. Please confirm it. Carbohydrates, I fear that it will be more of it. That symptom that wants to be fanned with slowly and fast and imperfect oxidation, what is mentioned in the literature, all is correct. When it will come is important. आज fever आया और आज ही SpO2 down हो गया. Will you think of carbohydrates in a young gentleman, in a hale and hearty person? If you read the literature, I doubt. Okay, carbo veg is slow, sluggish, can't rise to such an extent. You know, sluggish skin. थोड़ा और ऐड करता हूँ, lazy skin. Lazy skin मतलब स्किन में लेजीनेस है तो पर्सन में कहाँ जाएगा? इंडोलेंस, एवर्जन टू वर्क, एवरीथिंग इज देयर. इट्स अ कार्बन. ओके, एंड द बेसिक कार्बन भस्म है, वेजिटेबल चारकोल. Very indolent people, very indifferent people, right? The circulation is also sluggish, and that is what makes the oxidation improper. How this can be viewed? Okay, so it will come, so it will be rather a low grade fever, and after a few days, the person's SpO2 will fall. That's when carbohydrate can come up. No contractions of blood vessels, again slowness. So the blood won't move ahead. There will be venous stasis. Capillaries are engorged, right? तो ऑक्सीजनेशन होगा बट ऑक्सीजन आगे जाएगा नहीं, राइट? तो बिकॉज ब्रेन ऑल्सो वोंट रिसीव प्रॉपर ऑक्सीजन, so there will be dullness, there may be indifference in the nature, right? Indifference in the nature. How it is manifested? Wonderful, horrible or pleasant things. और हम इसको कोरिलेट करेंगे. Remember what Parag said, right? About peripheral receptors. Horrible things or pleasant things, अच्छा या डर वाला, do not affect him much. कोई इफेक्ट नहीं होता. कोई डराता है तो भी कोई इफेक्ट नहीं, कोई अच्छी बात करता है तो भी कोई इफेक्ट नहीं. विरक्त व्यक्ति भस्म है. साधु संत भस्म शायद इसीलिए लगाते हो कि ताकि विरक्ति रहे, तो यहाँ कुछ अलग मांग रहा है. हर्ड एवरीथिंग विदाउट फीलिंग, ये इंपॉर्टेंट. ही हैज हर्ड, बराबर, विदाउट फीलिंग और थिंकिंग अबाउट इट. And now just think what, just take your cortical cells a little behind. What Parag told, peripheral chemoreceptors, they are unable to perceive that lack of oxygen. Okay, heard everything, but not felt, not thought. And that is what will cause happy hypoxia. Okay, happy है कार्बोवेज के नहीं, ये तो पता नहीं, मगर हाइपोक्सिया तो डेफिनेटली है. Okay, another drug which has this is arsenic. Okay, and carbohydrate is a sluggish arsenic. Probably Clark says this. He may say, he may not say, but it is. Okay, arsenic also has this, a happy hypoxia. Where it is seen? Well says he is when very sick. उसको पता ही नहीं है. अच्छा. And when he moves, he finds himself too weak to move. Happy hypoxia. Carbohydrate. Venous stasis, slow, pulmonary improper oxygen. It goes to air hunger, where he wants fanning, becomes cold, chain Stokes breathing. 5 other remedies for chain Stokes breathing. If you want, morphine, opium, again a derivative of morphine, belladonna, yes, and atropine. How to differentiate? All have high grade fever. Carbohydrate, all are fast. Carbohydrate is slow. Why this slowness occurs? Some exhausting disease in the past. It is mentioned bad effects of exhausting disease. Second line of Allen's note. और भी ब्रैकेट में ड्रग है, वो भी पढ़ लेना जरा. Bad effects of exhausting disease. Either he had malaria in the past, typhoid in the past, or he is having an exhausting disease in the form of malignancy. That is going on. The system is broken. That is carbohydrate. The system is tired. That is carbohydrate. Passive hemorrhage होता है carbohydrate. कोविड में नहीं होता है, but the hemorrhage is also passive from broken mucous membrane. चलो आगे बढ़ते हैं. Lung fibrosis. Okay. COVID went away, but the patient has lung fibrosis, severe fibrosis. One drug, and I'll describe 2 drugs. I'll give the names. Drug affecting lung parenchyma, fibrotic restrictive pathology. Fibrosis is a restrictive pathology. Paralytic. Miasm of the drug is psychosyphilitic. Patient comes with dry cough, worse on lying down, worse night. ये इतना मिलेगा ना, 5 चीज आप प्रिस्क्राइब कर सकते हो ड्रग. 5 थिंग्स, दिस थिंग बस. Drosera is one drug. Hyoscyamus is another drug. But none are so psychosyphilic. Drosera is more tubercular. But that is not important. Again, Drosera doesn't affect lung parenchyma so much. Drosera affects bronchial tube so much. laryngeal affection is more in process. इसमें dry cough worse on lying down, worse on night. And if you read hearing, as the case will progress, it will be worse in the morning also. Severe weakness in the morning, debilitated in the morning. ओके सुबह उठता हूँ और टॉयलेट को जाता हूँ तो भी कमजोर हो जाता हूँ, नहा के निकलता हूँ तो भी कमजोर हो जाता हूँ. दैट इज दिस ड्रग एंड वंडरफुल रेमेडी फॉर डिप्रेशन. ओके लिखो जरा क्या हो सकता है. यूट्यूब जूम चैट बॉक्स एक्टिव है तो आ रहे हैं सजेस्ट कर. हाँ ड्रग इज Conam maculata, poison hemlock, depression and lung fibrosis. Wonderful drug for depression. Excitement causes depression. अब ये देखो हाँ rigid fibered old people. अरे बेचारा अगर कमजोर हो गया होगा old person तो he mean that rigidity may not be felt. Okay, but per se is rigid. Right? कैसे manifest होता है देखते हैं. Maybe having some glandular pathology in the form of hypothyroidism or even diabetes. Yeah. Excitement causes depression. So excitement in the form of fever has caused a depression. One, that is a possibility, or two, the personality is such. चलो बर्थडे पार्टी करते हैं. कोविड में बर्थडे पार्टी नहीं होता, प्रॉपर बिहेवियर बराबर. चलो बर्थडे विश करते हैं व्हाट्सएप पे, सरप्राइज देते हैं. क्या सरप्राइज देने का? He doesn't show much interest, indifferent. He doesn't like to engage in communication with people. Okay, avoids people. उसकी खबर लेने मतलब पूछने आएगा कैसा है आपको. हाँ ठीक है और अंदर के रूम में चले जाएंगे. They like to be alone, but they want people also. They are afraid of being alone also. So like lycopodium, they will want somebody in the next room, right? And very quarrelsome. तो डिप्रेस्ड है. एक्साइटमेंट कॉजेज डिप्रेशन. लोग पार्टी कर रहे हैं, लोग एंजॉय कर रहे हैं, ये कहीं जाके कोने में बैठे हैं बराबर. रिजिड फाइबर एंड सी द लंग हैज आल्सो बिकम रिजिड. फाइब्रोसिस, राइट? वेरी मच लाइक नाट्रोम्यूर. सैडनेस एग्रावेटेड बाय सिंपैथी. आई टोल्ड नो समबडी से कैसा है आपको, ठीक है दूर, आप ही दूर हो जाओगे, तो बताने की जरूरत नहीं. बट again has craving for salt like natramur, but sun amelioration. Chili patient, very weak chili. Two more drugs, Silicea and Philandrium. You can form drug pictures for this. Right? Interesting, very important drugs, Philandrium and Silicea. Bronchial affection after COVID infection. Okay. Bronchial affection after COVID infection means the infection has gone, but probably that hyperimmune response has stayed, right? Or the infection has gone, hyperimmune response is also gone, but after a month or so, he may come down. Okay, 3 drugs for this. Obese patient, history of recurrent respiratory tract infection, initially comes with mucus in the throat causing hoarseness of voice. Cough worse in cold, and the cough causes chest pain. Concomitants are severe weakness and coldness. Dyspnea better by lying down. Ammonium carb में worse by lying down था. Ammonium carb में worse by sleep था. Severe weakness, and yes, there is coldness in bronchitis. Can go till bronchioles also, but not more. Catarrhal affection destroying the mucosa, बराबर? Causing accumulation of mucus and then probably infection. One tip, generally पुरुलेंस नहीं होता है कोविड में, तो सपरेशन हो ये हो ऐसा नहीं होता है बराबर. But if there is a destruction of mucous membrane, then later on there can be a supervening infection, bacterial or viral. But per se that is not COVID. Right? Gradually progressive. The drug is a drug complementary to arsenic and phosphorus. The patient took arsenic, he was better, or took phosphorus, was given phosphorus and he improved. Complementary to phosphorus and arsenic. काली बाइकॉन. तुम बोलोगे सर एग्रावेशन 3M दिया ना, वो कंफर्मेटरी सिम्टम है. एवरीथिंग विच इज एग्रावेटेड एट नाइट 2 AM 4 AM 3 AM 2 or 2 AM 5 AM these can be misguiding symptoms. You don't enter a case with that symptom. You don't enter a case with that symptom. They may not be present when the patient is presenting to you, because he has already taken many drugs. The susceptibility would be lowered. The characteristic symptoms may not come forth so well. Barabar? Sure. Next. Second drug for bronchitis, known case of psoriasis or pustular acne or pulmonary tuberculosis, past history of tuberculosis, not present, पहले होके चला गया, क्योंकि present हो तो भी possibility है पर कम possibility है. A drug which is suppurative, per se suppurative, बराबर है. तो पहले जब टीबी हुआ था तो बलगम निकलता था, पीला रंग का बलगम निकलता था, and now he has bronchitis. During COVID, he had a history of fever at night, nightly aggravation. And now he comes with cough aggravated at night, with chest pain worse, especially on the left third rib. You can't be so specific, more left side. Okay. A drug with tubercular myalgia. Purulent sputa again is due to was when there was tuberculosis. Suppurative tubercular myalgia. Right? Drug is affecting left bronchus, lung, and skin. So lung and skin both are coming. This shows the importance of past history. Okay, gaya hai psoriasis और अभी चल रहा है. What drug will come? Pix liquid. Pix liquid as well. Okay. Bronchitis after COVID. Syphilitic myalgia. This drug can come rarely, which I am going to tell, but it is coming along with these two. Syphilitic myalgia. Known case of cancer or pulmonary tuberculosis or bronchitis. Winter cough. Winter is coming, friends. Cough in winter के लिए it's a very good remedy. Better by one, just like arsenic. Heaviness over the sternum. Heaviness over the sternum. Again, history of pulmonary tuberculosis with purulent sputum. Syphilitic drugs will have purulence in sputum. Arsenic will not have so much of purulence. Destructive changes are seen on X-ray. Collapse. Parag had told, no? Collapse could be a complication of COVID. Bronchopulmonary. Drug is having gangrene of lung. There is nothing like gangrene of lung which I have seen, but I have seen collapse. One lung fully collapsed. I could see a black shadow. Drug is creosotum. Creosotum. Okay. So 3 drugs. There are few more. Some other day. Right. Coming to heart. दर्द दिल की आहट तुम ना समझोगे कभी. दर्द का मातम सरे आम नहीं होता. They keep emotions with themselves, and let me tell you, COVID is perfectly qualifying for a stressful time in life of everyone, in terms of business not doing well, expenses increasing, adapting to different lifestyle altogether, the lorosirosis life I just told you, and these patients can get, I mean, you know, अपने दिल के मुताबिक ना हो तो दिल बैठ जाता है. Okay? और ससेप्टिबिलिटी है तो जरा ज्यादा ही बैठ जाता है. Which are the drugs? History of hypertension and ischemic heart disease in this drug. Okay. Low fever with severe body pains. It can be a low fever or can be moderately high fever, but definitely there is onset of septicemia during COVID. Remember, this drug has that. With severe body pains, so LDH may be high, CRP will be high, cardiac event may be there, angina pains. I gave away the drug. इतना बोल दिया बहुत है. ऐसा पेशेंट बोलता नहीं. Okay. Left elbow pains, nobody says like that. Okay. यहाँ दर्द होता है, बस इतना बोल. Okay. Severe anxiety and fear of death like arsenicol, a drug affecting coronary and cerebral circulation both. You can write down what is coming to your mind. Avoids the doctor like arsenic. Super. Hey, I gave that. This I gave that. A drug which is anti-infective, anticoagulative, has a rheumatic element. Bruise feeling in the back. या बाद में पूछेंगे तो ही बहुत बताए. Because these patients will generally avoid. Okay. Arnica is better for heart. Yes, for heart. Okay, they will avoid you. They will be brought to you. Okay, just like arsenic are. But they are a bit aggressive than arsenic. Cursing, swearing, dominating. Well says he is when very sick. मला काय नाही. कोण तुम्ही? But arnica. They will not allow a person to approach him. आप बोलेंगे इसी से निकल गए. काय नाही मला काय नाही. मतलब बरं. Right? And this can be catastrophic in a cardiac patient. And that's how they may land up to you. They may have a chronic infection and chronic cardiac problem, and then too they may land up to you. This is a very famous homeopathic drug for cardiac patients. Don't be surprised when I say this, arnica. Okay, but nightly attacks of anxiety like arsenic. Arsenic would be a little milder. Even arsenic would avoid you, but on a little milder way. They will not speak. Arsenic is aristocratic. Arnica is aggressive. Label. Right? Another drug. Wonderful. Heart muscle. We are going well. Okay. Give a thumbs up or a high five. We are going well on the Zoom, on the chat box. Okay. A drug which affects conduction mechanism, SA node and AV node, and definitely will be a good drug for arrhythmia, sore limb and trembling. Sore limb like arnica and trembling is different for this. So trembling, it means nerves are affected. Palpitations, wakes up at 2 a.m. with palpitations. Stitching pain, maybe there, may not be there. Right? Very good drug for cardiac debility after influenza. Drug is with choking in the throat and vertigo. Iberis amara. Iberis amara. Okay. Another drug for cardiac debility, but with left ventricular failure. Left ventricular failure. Poor ejection fraction, and also a good drug for lung fibrosis. Okay. Constricted feeling in the constricted feeling in the chest. Aggravation by sleep. Okay. I gave away. Pulse irregular in force, regular in rhythm. Irregular in force and regular in rhythm. Regular in rhythm means there is no arrhythmia per se. Irregular in force means it is pumping at times more, at times less. This will only happen when the ventricle fails. Ejection fraction is poor. Gave away. Naja is the next. Wonderful remedy, friends. Wonderful remedy. Okay. Think about both Iberis and Naja for cardiac debility after COVID, after influenza. Anxiety for health. Both have anxiety for health. Okay. Both will show a fear or a reluctance to start the treatment. But Naja more out of suspicion and Iberis more out of a fear of taking too much medicine. In these era, many are taking lot of medicine. Ayurved bhi le rahe hain, Kada le rahe hain, vitamins le rahe hain, Arsalb le rahe hain. Or observe constitutional medicine. It becomes difficult to digest. Right? Fear of taking too much medicine. Naja, on the other hand, would be very skeptical, very suspicious. He will be afraid that this one more medicine will injure me. Fear of being injured. Delusion, I'll be injured. That is Naja. He will confirm of the side effects. आपके दवा का कोई side effect दोनों साथ में लूंगा तो कोई side effects आएगा क्या? Skeptically पूछे. And then they may take it. Okay, very good drug for depression. Okay, they take too much on themselves. They take too much on themselves and then feel like a failure. They feel that they are not up to the mark. And when this feeling comes in COVID, it becomes difficult. For Naja, it becomes all the more difficult. Because of me, because of this job of mine, because of this profession of mine, I was exposed to COVID, and because of that, now I have transmitted that infection to my parents, to my mother. That is the feeling. It's utter failure, feeling of an utter failure of doing everything in a wrong way, and that can lead to suicide. Suicidal thoughts, suicidal from sad thoughts. Okay, two more drugs, Lobelia and Digitalis. Digitalis for cardiac failure, right-sided failure after viral illnesses. Okay, we are gradually moving from CVS to CNS. From CVS to CNS. Okay, should I continue or you want Dr. Parag? Dr. Parag seems to be in a hurry. If anybody has any questions for Parag, then they may finish it off so that in case he wants, he may. You know. Hello. Okay, I'll continue. Okay. High fever with high CRP and IL-6 levels, high D-dimer levels. So there is an onset of thrombosis, onset of DIC, a wonderful drug for septic fever with a stuporous state. Sepsis going to thrombosis, a state of DIC, and may emerge in the form of a stroke, CVS or CNS, more strongly CNS, more suffocates in sleep. Right-sided paralysis. Shining red tongue is a confirmatory symptom. You do that in the end. Crotalus horridus. Crotalus horridus. Yeah, so we can, I will just take a pause over here. He can start off and then when his question and answer session finishes, I'll take over later. Not a problem. Not a problem. Let me just finish this once. Just go through this version what a patient says. Does homeopathic medicine have any side effects? Why do you ask so, sir? नहीं, मैंने बहुत होम्योपैथ को पहले मैं मिला हूँ, लेकिन जिसका भी दवाई लेता हूँ मुझे रिएक्शन आता है. Best homeopaths he must have taken medicine from. People who are prescribing single medicine, classical homeopathy, and that is doubting because I get reaction from it. He may be right, but now that has created a fear psychosis. Here he will not be able to bear any kind of medicine. और सर ज्यादा हिस्ट्री लंबा मत लेना, पूछते बहुत है. There is no depth in this patient. After case taking, they'll refuse to take the medicine. I have come across a couple of these patients. बराबर. Fear when selecting the remedies. ये दवाई का भी reaction नहीं आएगा ना. Fear of serious thoughts. Crotalus horridus. Right? Known case of obstructive sleep apnea, history of fever with high IL-6. There is no high CRP over here. So that septic element, that vascular element is gone. It is more neurotoxic. Stertorous breathing showing that there is obstructive sleep apnea, stuporous, and a very good drug for hemiplegia and myelitis. So neural involvement. The drug is more neurotoxic and less septic. One of the only vipers to be neurotoxic. Viper snakes are generally septic. Elapids like Naja are more neurotoxic. This is one snake which is more neurotoxic. Okay. Few more confirmatory symptoms. Thoughts of death when alone. Dreams of dead ghosts. Dreams of dead and ghosts. Plaintive speech. I had been to one college which comes across Nashik Road, Abad Homeopathic Medical College. There I had a rendezvous with Dr. Abad of Materia Medica department. He had prescribed this when I had gone there, Crotalus cascavel, और उन्होंने बोला मैंने plaintive speech के पे दवाई दिया, मगर उससे ज़्यादा मुझे पता नहीं है इसके बारे में. मैंने बोला सर dreams of dead भी है, and patient had that too. He had prescribed it. Wonderful doctor and wonderful college, and there I had this experience with Crotalus cascavel. Conversations across a table with wise men can lead to wonderful ideas. Parag, you want to take up the question answer session? Bhagwat madam? Yeah, Parag. Yeah.
Thank you, Dr. Chintan. Sorry for interruption. Dr. Parag has some emergencies to see. So there are few questions for Dr. Parag. So I hand over to Dr. Vinod Sawant to direct the questions for Dr. Parag. So Dr. Sawant, please go ahead with the question and answer session. Dr. Sawan. Dr. Parag, if you have questions seen in the chat box, you can go ahead with the answers.
Yes, ma'am. Yeah.
Yeah.
Yeah. Am I audible?
Yes, yes.
Yes, I have a list of the questions which have been put forth to me.
Yeah.
So starting from the first one, I think it's from the first question which has come in is regarding this guidelines from COVID-19 from Akshata. So she wants some tips on how to kind of approach these patients who are coming to us after COVID in a post-COVID kind of a OPD visit, and how to kind of focus on the uncertainty in the clinical outcomes. So basically, Akshata, I'll be focusing and talking about some red flags that would be an acute thing. But in a post-COVID scenario, first of all, you will have to look at why, what are the presenting. So the approach will remain the same. It is like any other OPD patient that you will be treating. But the important thing that you have to keep in mind is the differential diagnosis and the possibility of a post-COVID sequelae. Am I audible? Hello.
सर आपका म्यूट हुआ है सर.
Yeah, sorry. So, yeah, Akshata. So, if you want the guidelines, there are no written down guidelines, but I'll tell you one, two, three sort of a thing. That first of all, you have to look at every patient as a naive patient, and you have to approach them with equal open-mindedness and kind of a very clear clinical approach. So, whenever you are taking the history, you have to keep in mind the post-COVID-19 sequel, which I just enumerated. In fact, there will be more which will be reported and which will be described later on also as the days pass by. And so we need to kind of keep ourselves updated. So that is one. The second thing is obviously that if you have a patient who is persistently complaining of a particular symptom, say somebody is coming up to you repeatedly with a cough and has not received or has been kind of overlooked in terms of investigations for say a pulmonary evaluation, then you have to kind of get a proper evaluation done. Say unka x-ray hua tha and x-ray was passed off as normal, there's no follow-up being done. So get an HRCT done, do a saturation check. If you want, you can also do a kind of a lung function test. That is, we have now started doing pulmonary function tests or office spirometry for our post-COVID-19 patients who are now preparing up or gearing up for a rehab, because it helps us monitor it serially. Similarly, for a cardiac kind of a thing, say somebody is complaining of vague chest tightness, X-ray was normal, saturation good, but the pulse rate is abnormal. You look for the ECG, 2D echo, get a evaluation done so that you can identify heart failure early on. Similarly, for pedal edema, patient is complaining of itching of the skin, maybe the kidney injury was missed out during the acute phase, and so that is what we need to address properly. And so that remains very standard. There is no set guideline for it. Yes, the vitals have to be assessed. Your oxygenation is very important. You can also do what is known as a 6-minute walk test for these patients. So we generally ask them to kind of check their saturation at rest, and then we also ask them to walk for about 6 minutes. We measure the distance as well as the drop in oxygen levels, and we note that, and that there are specific laid down criteria for that, and how much a desaturation of more than 3% is generally considered abnormal, and that would be indicative of some underlying pulmonary insult. And similarly, if you have a disproportionate tachycardia coming in, that means probably there's something wrong with the cardiac issue, right? Now, I think that addresses your COVID-19 follow-up patient. The next question is from Prajot, and he has a very specific and interesting question: the sensitivity and specificity of diagnostic tests. There's a very good question, Prajot. Let me compliment you. So I'll put it very clearly. The RT-PCR is the gold standard for diagnosis. I had put it in my slides also. It has a sensitivity of the tune of 70% in ideal settings. In an out of ideal settings also, in a clinical practice setting scenario, there are several variables to it, and the sensitivity may be slightly lower. So somewhere around 50 to 70% at best you can consider, and its specificity is going very high, so to the tune of somewhere around 95 or 100%. So that is one thing that you cannot deny, that RT-PCR if किसी का positive आया है, so he or she either is having an active or developing COVID-19, or probably had developed COVID-19, and whatever you are identifying are remnant fragments of the coronavirus in the sample which you took. And that is why, after the 10th day or 14th day, initially in the first few days, weeks of the pandemic, we were doing follow-up RT-PCRs to kind of rule out, confirm viral clearance. But then we found out that there are a lot of people who tend to shed virion particles, or parts of the virion, and reported as RT-PCR positive. That would give to a false sense of alarm, and make them prejudiced, or subjected to kind of discrimination. And so that is not needed now that we have data, we have a lot of literature which has proven that after the 10th to 14th day, the virus replication drops down exponentially, significantly, and it's negligible. It's like a non-transmissible sort of a state. And so at that point of time, the specificity of the RT-PCR is basically for early diagnosis, not in a follow-up kind of a thing. Having said that, let me tell you that it is important that we do RT-PCR screening before undertaking any medical procedures and all that. The idea behind it is that anybody who has not had a history of COVID-19, or could be possibly a long-term harbor of COVID-19, say the long COVID-19, which I mentioned, we don't know the implications of long COVID-19 yet. And so such patients could be chronic silent carriers. We are not very sure about it. So that is where it makes some difference. And, we are a bit careful about interpretation of RT-PCR in that light. The antigen testing is a good screening or a surveillance test, which is being extensively used by our corporation now. And the government has had a huge stock of antigen kits, which they have bought. So they have to put it to good use. And I'm pretty sure that WHO and other international bodies also ask for the antigen kind of test levels which are prevalent in the population, because that has statistical significance. And apart from that, the antigen has not a great sensitivity. It's also to the tune of 30 to 40%, but the specificity is quite high. So if somebody's got an antigen positive, again, there are two schools of thought. Somebody would say that you don't need to do an RT-PCR. Somebody would say you should. I would look at it from that point, that an RT-PCR, now that the cost has come down, availability is better, and our people are more experienced in doing the test, everybody should undergo an RT-PCR if an antigen is positive. Okay, that was about the RT-PCR and the antigen. Antibody testing. So antibody testing is done only for confirmation of evidence of infection, which is now gradually gone, or it is in the going phase. So it is the later part of the illness, and it will help you document immunity against the SARS-CoV-2. Let me tell you that we do not have evidence right now that the antibodies which are developed innately in human bodies are 100% protective against SARS-CoV-2. Had that been the case, we would not have had cases of relapse or reoccurrence of SARS-CoV-2 in patients who have had it in the past. But we do have reports coming in from all over the world. And so the antibodies really are not necessarily completely protective. So they are not very useful in terms of diagnosis. Radiologically, if you were to look at X-rays are not a very sensitive, neither are they very specific in terms of diagnosis for COVID-19. In fact, for that matter, any pathology for that, except for probably a pleural pathology, you do not rely too much on parenchymal infiltrates in terms of kind of radiologic correlation with the exact pathology. So an HRCT would be important. How sensitive is an HRCT? The HRCT in the early phase of the illness, I had shown in my slide, has a sensitivity somewhere around 30 to 40%. With passing away time, so with the third day, fifth day, seventh day, HRCTs tend to have better yield, and they tend to have a sensitivity which improves and goes up to the tune of 60 to 80%. In fact, there will be instances where I had shown in my slide also, you will come across an infiltrate, a silent sitting kind of a shadow somewhere in the corner of the chest, with no other symptoms coming in from the chest, and vague kind of vague extrapulmonary symptoms coming in. You are evaluating the patient primarily for an extrapulmonary problem, and that is the giveaway sort of a thing. So HRCT tests are very good in that sense. The specificity also goes beyond 90%, especially if you have a high CORAD score and it's the first CT study which is being done. And if your radiology colleague is experienced enough, that is important. So they'll always, keep you in the loop, and you always have to keep them in the loop also. It's a teamwork. So RT-PCR is very objective. HRCTs can be more objective if you form a team with your radiologist, right? That was about the diagnostic part. I hope, Dr. Prajot, I have answered your question satisfactorily. The next question, I think, is about the red flags, which you had put, that what red flags do we look for in terms of COVID-19 patients coming to us. So any COVID-19 in the acute illnesses, you have to be very careful, for any other illness also for that matter, but here especially, you have to, I had three to four times in my presentation, I have stressed on the high risk group. So please remember that. If you want, I'll send it across to you, or you can always go back on YouTube and check it out. So anybody who's elderly, anybody who is, male sex, anybody who's been a smoker or an alcoholic, anybody who's got a comorbidity, either, a chronic pulmonary disease or a cardiac impairment, or somebody who is pregnant, and somebody who is, having a history of either a tumor or a kind of a oncotherapy in any form, either chemo, radiation, or something which could, impair their cell-mediated or other immunity, or somebody who is an organ transplant candidate or a recipient. Organ transplant candidates are all immunocompromised because they have major organ dysfunction. So these are all high-risk groups. So when you are taking the history, you have to keep that in mind. That is going to be the clue. Then you will look for the vitals, any derangement beyond kind of the expected or beyond the normal. Somebody who's got fever, you will expect tachycardia. Somebody who's got fever, you will expect them to have some degree of weakness. But if the prostration or weakness is not correlating to a mild fever, or if your patient is having disproportionate myalgias compared to the onset of the illness, say your patient has got a cough and a low grade fever since one day, and then he starts complaining of severe joint pains and body ache, you have to be very careful. These are abnormal kind of derangements which you have to keep in mind. Most important is the fifth vital sign, that is the pulse oximetry. Please always invest in a pulse oximeter, keep it in your pocket. These are the times when, see, we as chest physicians have always been kind of pushing for the use of pulse oximetry as a vital sign. And now more than ever, the world realizes that. Of course, there's another question to the quality of pulse oximetry, so I'll address that separately. But this is very important. So it will give you several clues upfront. So a pulse oximetry in a relatively warm, perfused finger should be a good indicator of the hypoxemia level, right? Similarly, it will also give you a good clue to the level of the kind of perfusion and the level of volume kind of intravascularly moving in the patient. So somebody who is very cold, sweaty, you try to give them a kind of a rub on the palm and then put the pulse oximeter, and yet you are getting a poor reading. You have to be careful. It could be cold hands, but no, you have addressed that part. So it is not a cold hand. So either the patient is less perfused, and the oxygenation is dropping. Yeah, and so that was about pulse oximetry as a red flag. Any abnormal mentation or altered mentation, altered cognition, somebody becomes increasingly forgetful or altered in terms of their orientation to time, place, and person. or develops unexpected kind of symptomatology. So suddenly getting a rash, suddenly getting kind of, pedal edema out of nowhere. Be careful. These are, takeaway kind of signs or telltale signs which you should be very careful about. I think that should be a good sort of a red flag enumeration or summary of the same. Um, of course, it is not by any chance complete in its own self, and we will keep learning. Dr. Vinod Sawant had a question: what is the role of steroids in cytokine release syndrome? Right. So, yeah, that's another good question. Of course, pathophysiology is, we are still learning, and it's like, to be very frank with you, this is more like a flower which is multi-petaled, and we are peeling off one after the other petal only to find more and more layers. So it is COVID-19 is, something of more of a interesting story to us, and steroids have been tried very early on, and they have definitely secured their place in cytokine release, not in cytokine release syndrome, but earlier, before than that. So you would not want to give somebody a high dose of steroid. You would want to give them a mild to moderate dose of steroid, and that dosage should be timed in a way that the patient is about to develop a cytokine release kind of a event, or has, is in the early phase of the cytokine release. If you are going to bomb them with a high dose of corticosteroids, it's not recommended, and neither is it recommended later on to be given in a full dose, because by that time a lot of damage has already been done, unless of course you are giving it from the intent of salvaging a part of the lung, or improving the ground glass opacities if you have documented them on an HRCT. So traditionally, we have considered GGOs or ground glass opacities on HRCT as a sign of pneumonitis, and they could be steroid responsive. But fibrosis is not very responsive to steroids alone. And steroids are a double-edged weapon or a double-edged sword, as you all know. So they have their own set of benefits, and they have their own set of limitations or side effects also. So somebody who is not experienced or is a novice in the use of corticosteroids should avoid them. Uh, Otherwise, they are definitely recommended, as I mentioned early on, in a moderate dose, and to patients who are earlier in the illness and not in the full-blown release syndrome. They only have a supportive role. The primary role then would be taken up by the anti-IL-6, that is tocilizumab. Sadly, tocilizumab has not succeeded too much in clinical trials. The RCTs are not favoring it too much. But to be very frank with you, my own experience with it has been reasonably fair, and my colleagues in other centers as well are not too complaining about it. So if you give it in the right time, early on, and in the right dose, it generally helps. Now, it is like in SARS-CoV-2 with a ICU patient who is landing up with a cytokine release syndrome, or an ARDS or a lung injury sort of a thing. It is marta kya nahi karta. So all those people who are, kind of, talking very strictly by the book, and those who say that this is absolutely not done and this is absolutely done, I have only one thing to tell them, that we are still learning, and the final verdict is not yet out. So please bear with it, and trying new medications under supervision in a trial sort of a setting is very, very appropriate, and it is a scientific thing to do. So let us not look down upon anything. The same thing applies to alternative systems of medicine also. And so if you are kind of considering any specific medications or therapeutics in terms of uh, homeopathy, or even for that matter Ayurveda, they are most welcome to be tried under the aegis of trials being run by the Ayush. The next question is on quality of pulse oximeters. So the quality of pulse oximeters right now the quality of pulse oximeters which are flooding our market right now are questionable. But with the amount of need of the pulse oximetry that you are having to do, you cannot wait for a consignment to come all the way from some Nordic country the couple of brands which make very good kind of pulse oximeters would also charge a premium for their brands, and they would also kind of be in short supply, because let me tell you that now the world has seen the discrepancy of the rich versus the poor more than ever. So the countries which are resourceful and who have the money to spend have cornered almost all the supplies of PPEs, N95s, oximeters, and even the ventilators for that matter since quite some time. Now, since India has decided that it is going to manufacture its own kind of stuff, you will have to give them some time before they rise up to it. Till that point of time, you'll have to make do with acceptable quality of pulse oximeters. I would not be downright critical of these pulse oximeters, because in the given scenario they cost anything between 500 to 1500 bucks, which is affordable for even, I would say, a relatively poor gentleman. For once, it's a one time buy, you are not going to buy it again and again. Everybody in the family is going to use it, and so I think it's a worthwhile investment rather than investing into costly data plans for people who really are not going to do anything else except WhatsApp and video calls for socializing. I think this is a worthy investment. So the quality of pulse oximeters may not be great, but they are acceptable.
Sorry for interrupting, Dr. Parag.
Yeah,
Yeah, because of the lack of time
no
restriction,
problem.
we have to.
Fine, no problem.
I'm requesting the other viewers and the participants to send the questions to us. We will give it to Doctor. We'll proceed them to the Dr. Parag Mehta. And because this is such an interesting session and such a hot topic, the session will be never ending.
Yes, very true. I agree to that. And even I need to rein in my enthusiasm and, answer my prior
It
obligations.
was so enlightening session, sir. But for the time restriction time, we will
It's
send
fine.
the questions to you via email or something.
No
We'll
problem.
make those
I think this is on
arrangements.
YouTube also. So I think if they are going to kind of, add into the YouTube kind of a
Yeah,
chat box,
your
they
contact
will.
number can be provided, sir, in the chat box, so that
I think madam has it. So I think she can display it whenever she wants to. No problem.
yeah. Thanks a lot.
Pleasure. Take care.
Dr. Swati, Dr. Swati
Yeah,
will take over.
Yes.
yeah. I think now, Dr. Chintan Mehta, you can continue with the remaining slides of yours
I'll take your leave,
in
madam. Thank
short.
you.
Dr. Chintan, Dr. Chintan, start.
Yeah. So, okay, a drug which affects the central nervous system, causing thrombosis and then stroke. Uh, Again, this is very simple. Right-sided paralysis with aphasia, another vipera, another viper from viper family. One more drug, interesting, going from legs to lungs. You know the symptoms which are there in the legs. It causes DVT, but what is interesting, if you refer those books, it is also a good drug for pulmonary embolism. The pulmonary embolism. Tachypnea, very fast and paced, arrested respiration in 2 hours after that, after this drug, within 2 hours. That is a symptom given in Materia Medica 4. I'll show you. Oppression of chest with anxiety, making violent efforts to breathe, look of terror and anxiety on the face. That's how you catch up a vipera. Vipera. Okay. After hospitalization, you see, after the viper bite, after hospitalization, the patient suddenly ceased to breathe. Heart stop. And what is interesting is that the blood was mixed with dark, bright streaks. With bright streaks. Thrombotic event had begun, and the first symptom, anxious, oppressed respiration after 2 hours. Okay. Tore his shirt because suffocation threatened. The theme is of survival. I want to breathe. I want my life. That's why there is tearing. There is desperate attempts to come out. Vipera. Post-COVID weakness, fibromyalgia. अंग्रेज चले गए, अंग्रेजी छोड़ गए. COVID went away, weakness came up. First case is very easy. One of gelsemia will present with laziness, inability to work, who wants to work with a history of thirstlessness and a low-grade fever. thirstlessness, chilliness, low-grade fever. Gelsemium is a drug during COVID. Many doctors are using it, well experienced, very important drug. Another thing, discernings are lethargy as per boring. Another interesting thing in gelsemium, along with naproxen, is myocardial degeneration after influenza. And Guillain-Barré, which Parag was talking about. Very few patients are here. Guillain-Barré syndrome, gelsemium. Two drugs for convalescence phase. Fibromyalgia with severe weakness, severe prostration, and irritability. Rheumatic pains, long-lasting pains, just like a brand. Aggravation by motion, better by pressure, but a tinge difference. The past history or the present history. History of tuberculosis and renal failure. Drug is formic acid. Formic acid. Same complaints of prostration, irritability, but with a rheumatic complaints, and flatulence. More windy, sour irritations, offensiveness of breath. Flatulence and offensiveness साथ साथ आता है. Drug is one which is there in China, one which is there in colchicum. The drug is salicylic acid. Okay. History of intermittent fever with joint pains and draft sensitivity. Worse in forenoon with increased appetite. China, very simple. Okay. Worse in forenoon. Worse in night. Think 10 times before giving just China. Think 10 times. If it is worse at night, the fever worse at night, don't think 10 times before giving China. Intermittent fever. What if it is a remittent fever? Okay. Remittent fever with draft sensitivity, presence of constipation, and aggravated by loud reading. In this time of COVID, I have seen many of us working on the web, taking lectures on Zoom, aggravated by loud reading. Okay, the vocal cords are affected after COVID. Selenium is the drug with constipation. Not rare drug, very commonly used drug, but continuous fever. DD is Stenospora, China self. China are Stenospora cordifolia. If any one of you get the chance to use, do use it. It may come up for a very simple reason. लोगों ने भर के गुड़ूची खाया है आयुर्वेदिक फॉर्म में ये कोरोना के टाइम में and without consulting an Ayurvedic physician. Okay, so the dose was not regulated. Could be they may suffer from crude effects of Stenospora. Stenospora is nothing but guduchi. Now this is interesting. This will give you an idea as to how things work. History of fever, continuous fever. SpO2 was a bit low, but no ICU admission, known case of asthma. And now comes, this is so weak that if he walks a little, he must lie down, becomes very breathless. Severe weakness, must lie down with breathlessness. Slowness, appetite is low, constipation is low, the entire system has become slow, but he is very anxious. See, he has recovered and he is anxious. He is recovering and he is anxious. Not recovered, he is recovering and he is anxious. He has improved and he is anxious. Okay. Drug is Suriname. Okay. A businessman whose business is prospering feels he will have to go to a poor man's house. That is Suriname. अच्छा ही चल रहा है, improve ही हो रहा है, cure नहीं हुआ है, but improve हुआ है. But he does not acknowledge that, rather he becomes anxious and depressed. Suriname is high fever, just like belladonna. Okay. Another case. SpO2 with ICU admission. Okay, severe weakness, severe chilliness, hardly any characteristic, and CT scan is showing marked fibrosis. History of fever with red lips. ये hint है, हो भी सकता है, नहीं भी हो सकता है, but just fever may be present, may not be present, but weakness था, and SpO2 was very low. Tuberculosis. See, this patient is hardly complaining, although he is not well. That is tuberculosis. Okay. This we can go old age sportsman, known case of diabetes mellitus, comes with dyspnea on palpitations, loss of sleep, tired state of affairs. Coca is the drug. You can read it from Ellen's clinic. During convalescence, patient's pneumonia is better, but it has not improved. Young man with a hypertension or sleep apnea. Young man. When young man comes, it means it's some problem. At young age, he is developing this. Now comes with history. During COVID, the fever was worse in evening, and he had sour irritations during fever. ये in retrospection of past history में पूछ सकता है. But the X-ray is showing consolidation has improved, but it is not fully resolved. Right? Cough not relieved by expectoration. Maybe going into respiratory distress also. Lycopodium is the drug. Convalescence after fever, this is the only drug present in synthesis repertoire. Known case of hypertension coming with a history of pneumonia. Pneumonia में क्या हुआ था? High fever with dry cough. Worse at 12 a.m. or 12 p.m. Consolidation is not resolved. And there is interstitial. Maybe in chronic state, there may be interstitial lung fibrosis. Maybe. But initially, you are getting those signs. Lung parenchyma is what. Bryonia was given initially, but did not relieve much. And now he comes with cough, again worse at 12 a.m. and 12 p.m. And because that was not given properly, treated properly, he goes into suffocative attacks, worse at night, and desiring open air. Suffocative attacks, worse at night, desire open air in a non-resolving pneumonia. The drug is very clear with a thirst and dry red lips. Arsenic will not want open air. Arsenic may not have dry red lips. May have dryness but not red. And again, this suffocative attacks, aggravation at night, wanting open air, check out Allen's chemo. Bryonia was given, not really. And a good drug for non-resolving pneumonia. Okay. Dawle sir, M.L. Dawle sir, late Dr. M.L. Dawle had cured a case of pneumonia with sulfur which was not resolved. These are rubrics from synthesis repertory for convalescence phase and in sulfur. Remedies for depressed psychiatric problems. I am giving you the names of remedies. The list is endless. Full case taking is required. You can't give list, but just few gifts from my side. Arsenical, Nozors, and Lactose. These are the rubrics which can come up with patients of OCD. Anxiety, sedentary life, graphitis is the problem. Anxiety when alone. Very common rubric coming up. Fear of infectious diseases, infection. Caladium is a drug for fear of infection. Okay, and the patient can become suicidal from anxiety. Anybody who thinks anxiety is a psychotic miasm, I don't know what does this rubric mean. Suicidal from anxiety. Depression, sadness, after losing money. Arnica is there. See, furinum is there. Very common. People have reported a lot of losses. You want cases, or I can just hand up over here and yeah, admin. Like to go for cases or would like to go for question answers from here? I have two cases, but I think we can start question answer session. Dr. Sawant?
Yeah. Again, with the lack of time, we will take some important questions. One second. Yeah, there are a lot of questions, but we will take few with the due to the restriction of time.
I don't have to answer other questions after I am.
One question was on potency selection.
What?
Potency selection.
This question after every seminar of Materia and therapeutic somebody has was this is a question of organon. Yeah. Understand one thing. If you are giving a drug, if characteristic symptoms are prominent, potency will be high. If pathology is not, is just at the functional level, if fever is high and you're sure of the drug, 200 and above can be given. Still, because somebody has asked, and this is the first question, if subjective symptoms are more, you have characteristics at these levels. Give high, medium to high potency, 200 and above. If objective are more, you hardly have any characteristics, go for low potency.
Yeah.
Another thing.
We'll take one more question.
Absolutely.
Your opinion regarding the virulence of COVID-19 virus versus host susceptibility. Like what plays more important role?
Come again?
The virulence of the COVID-19 virus versus the host susceptibility from the homeopathic point of view. What has a major toll?
Correct. Right. So Parag has already told of the virulence of virus. See, when the virus is causing viremia, at that time, few of the people have some symptoms, right? So So that shows effect of virus is not that big during that phase of viremia. Barabar, but basic comorbidity. Then the susceptibility starts taking a toll. Another thing which I found is, fortune will tell, but altered susceptibility many a times is seen in the form of, or an altered immune response would be seen in COVID, but before that, it would be seen in the form of constitutional symptoms. That is where early intervention with homeopathy is required. Before even a COVID starts, when the patient is healthy, if at all it has started, and then the fever has come and the other symptoms are coming, then definitely think the entire case would be required. But before, if you are starting, then it would be of much more help. I did so.
Yeah. Thanks a lot, Dr.
Thanks.
Chintan Mehta. Now, Dr. Neena Menon will take over.
Thank you all. Just a bit. Thank you all those who have come over here, attended this seminar or webinar. I hope it was a good learning experience and will help you treat your patients of COVID. Thank you.
Thank you, sir.
Yeah. Good afternoon. Thank you so much, Dr. Chindan Mehta and Dr. Parag Mehta, for giving this informative session. I know it's not constrained only for 1 or 2 hours. The whole day we can go on discussing on, because it's a new thing for us, because coronavirus disease or the COVID-19 is an infectious disease which is newly found. And when Dr. Parag Mehta, he has started with the introduction, followed by the lessons, what we have learned from the various type of infectious disease like SARS or the COVID or the MERS, etc. And he had gone into the detail and even the stages of COVID-19 progression, importance of the diagnostic, respiratory complications, and the indication, other complications affecting the other systems like CNS, GIT, renal system, and even he had correlated with the pediatric complications also. Even Dr. Chindan, while he had gone into the detail of the homeopathic therapeutics, where he had differentiated the common and the peculiar or the characteristic symptoms. So each and every case, we have to give more importance to the characteristic symptoms, considering the concomitants as well as the causative modality, and even the cases also, whatever he has correlated is also very much informative. And he already given importance to the pathology, pace of the disease, and miasm, how it should be analyzed also. And again, the importance of giving to the diseased patient rather than the disease. That's a homeopathic basic concept which should be considered. Even the rare remedies like lorocerrasus, or even comparing it with hydrocyanic acid, or even the tubercular drug like Phalanthrium, Pix liquida, Iberis, etc. also are very much informative. Now, when we consider the other drugs, just think of these drugs like alpha, vena sativa, gentiana, all this again. Now, nowadays, whatever we are getting the cases in the OPD also, again, gentiana, alstonia, all these are giving very much results. Along with that one, the medicines, even anti-Mars have been found very much effective. Natrum sulf is again another medicine. Again, you can, the post complications or the post-convalescence period also, it is very much. So finding, instead of going into the fear and anxiety or the correlated or the mental psychic complaints which are prevalent nowadays. So instead of that one, think positively. And the 3 things which have to be considered is, that is, the first is the social distancing, which we have to follow. That's the auxiliary management part. Second is the wearing of mask. And third is the sanitization, or the social distancing is the most important thing. So these 3 things which should be followed and which will help or prevent in spreading the disease also. Okay, thank you so much, Dr. Parag and Dr. Chindan Mehta, for your informative session. Thank you. And now I just invite Dr. Neela Masavale for giving the vote of thanks.
Good afternoon. Thank you, ma'am. Good afternoon, everyone. I, Dr. Neelam Asavle, Assistant Professor in Department of HMM, take the opportunity to express my gratitude to all the participants who had attended this session. First and foremost, I would like to express my gratitude to our chairman, Dr. G.D. Pul, sir, who is a constant source of inspiration, support, and guidance for all of us. Second, I express my sincere thanks to our principal, Dr. Pramodini Page, for giving us this wonderful platform for the national webinar. I also extend my thanks to our Vice Principal and Dean of MUHS, Dr. Bagal sir, for his unconditional support, constant support in organization of this webinar. Second, I extend a very hearty votes of thanks to our first speaker, Dr. Parag Mehta, for his efforts towards explaining the worldwide pandemic disease COVID-19 clinical approach and consequence. This was very informative session for all of us. Our second speaker, Dr. Chintan Mehta, we are grateful to our second speaker, Dr. Chintan Mehta, who is the Assistant Professor, PG Guide in Department of HMM, for explaining us in detail the homeopathic remedy for COVID-19, COVID cases. I am also very grateful to our chairperson of today's national webinar, Dr. Neena Menon ma'am, who is a professor, PG guide and PhD guide in Department of HMM, for moderating the webinar and giving her insight for the same. I also thanks to our coordinators, Dr. Deshmukh, Assistant Professor in Deputy Department, and Dr. Dhanraj Mistry, Assistant Professor in Pharmacy Department, and also Mr. Godse and his IT team for the technical arrangement. A special thanks for the organizing committee, teaching, non-teaching staff for their support and coordination. And last but not the least, our heartfelt thanks to our audience for active participant. With this, we are ending this session. Thank you.
मैडम क्लोज करूँ काय? एंड मीटिंग करूँ? हेलो